Okay, good afternoon. I think it's a pleasure to be again in Cairo. I am going to talk about, in fact, the management of metastatic breast cancer with endocrine therapy, and I will focus at some point on the potential role of Faslodex at a dose of 500. I will be very quick in the introduction. The previous speakers already explained the problem of breast cancer. Just on this slide to let you know that there are two types of breast cancers. The one we can cure, potentially, early disease, and the one we are not curing at this point, i.e. metastatic breast cancer. We had the weakness to think some years ago when we were developing taxanes, aromatase inhibitors, even anti-HER2 drugs, that we may be able to cure some metastatic breast cancer patients. But in fact, today in 2014, we are still not curing metastatic breast cancer patients. So the slides are... okay. Okay, when we look at metastatic breast cancer, we are not curing, but on the other hand, when we look at these slides, we realize that with the evolution of new drugs, we have in fact increased survival, and you should not mix cure, which on survival curves is a plateau, with in fact improvement of survival, which is the shifting of the survival curve to the right. And we believe in this study from MD Anderson that over the decades, in fact, the introduction of new drugs has actually improved overall survival. It was mostly seen in some trials in which there was no crossover. I will go very quick on the definition of breast cancer. The previous speaker has done that. But I want to focus now on the new classification, which is extremely important because when we use hormone therapy, potentially we are targeting luminal tumors. There are three types of luminal tumors. The two most frequent are on this slide. Luminal A, which is the most frequent potentially hormone-sensitive breast cancer with a high expression of hormonal receptors and a low proliferation. In contrast, the luminal B tumors are less frequent, usually have a lower expression of hormonal receptors, and they have a high proliferation. And I think we believe that the hormone sensitivity may be higher in the luminal A. I will not talk about the luminal HER2 positive, which is a very, very small subgroup. In terms of treatment, for a long, long time, we have based our approach on the prognostic approach. This concept was to say worse the breast cancer is, more aggressive, in fact, we should be with the treatment, either chemotherapy or hormone therapy. In fact, we are moving today towards more predictive approaches, and the prediction of hormone sensitivity is something which is extremely important to understand which patient should actually get hormone therapy. The first predictor is well known, it's the hormonal receptors. We still look at hormonal receptors positive, negative, while in fact the quantitative approach is probably important. In this slide you can see that patients with positive estrogen and progesterone receptors will do significantly better than those with only ER positive and PR negative, and indeed better than negative. One group here which is shown, which is ER negative, PR positive, is probably not existing, it's probably an artifact when we discuss with top pathologists. The second potential predictor is really grading. We know that grade 1 tumor usually are tumor which could be more sensitive to hormone therapy than patients with grade 3 tumor. In this grading, I think I give myself a lot of emphasis on the mitotic index. I believe that the mitotic index is extremely a robust predictor in terms of proliferation. Ki-67 has been studied in length. There are still some discussions to know what is the role of Ki-67. We believe that the threshold for low proliferation and high proliferation may be around 13 to 15%. Nevertheless, I mean, this is usually a definition which is complex to assess in the lab. So the robustness of Ki-67 is certainly lower than the mitotic index. So in my clinical practice, I use both, but I give more weight potentially to the mitotic index. Ki-67 was proposed by some of our colleagues as being a way to define a stratification between luminol A and luminol B. And finally, the HER2 status, just to mention it, patients with amplification of the HER2 gene overall are not extremely hormone sensitive. I'm talking about the luminol HER2 with positive hormone receptor. Usually they have a low expression of HER2, and we know that there are some mechanisms of resistance which are involved here. This slide is showing to you some data using letrozole, and the response rate and time to progression were not extremely good. What are the clinical implications for decision making? Luminol A are really patients who should be treated with hormonal treatment. The question in adjuvant setting is should we give chemotherapy to this patient? Luminol Bs are benefiting from both treatment, hormone therapy on one hand and chemotherapy on the other hand, and each patient will have to be assessed individually to understand her hormone or chemosensitivity. The HER2 positive tumors is a very specific issue. So in fact, when we look at the very simple cartoon to look at the indication of treatment, this is summarized here. In hormone positive group, clearly, hormone therapy is one of the mainstream treatment for luminol A for sure, and luminol B probably in sequence with chemotherapy. Well, the management of metastatic breast cancer is somewhere a complex issue, complex and at the same time relatively simple if you have clear ideas. When you have a new metastatic breast cancer patient, the key is going to look at the extent of the disease, the site of the disease, the disease-free survival, which is going to give you an idea of the proliferation of the disease, the hormonal receptor status, and clearly the HER2 status. And then you have two groups which are well defined. The first group is really here patient with no life-threatening disease, with positive hormonal receptor and HER2 negative. Clearly, in this patient, the recommendations, in particular, this is from the NCCN, is really to start with hormone therapy and somewhere exhaust the hormone sensitivity. So we give at least 2 lines of hormone therapy before moving to chemotherapy. In patients who are responding to several lines, we go down the hormone therapy up to the point where we believe there is hormone resistance before moving to chemotherapy. For patients with life-threatening disease or HER2 amplified disease, clearly we have a tendency to start with chemotherapy with anti-HER2 treatment if there is an amplification of the HER2 gene, and we go down the line in sequence. As you know, I think hormone therapy is known for a long time. As you can see on these slides, more than 1 century ago. And progressively, we went through different types of hormone therapy. And I like these slides, which is an old slide, in which we look at ablative hormone therapy, chemical hormone therapy, and all the hormone therapies in white have a characteristic, which is the fact that conceptually they were all the same in terms of efficacy. When I was learning medical oncology in the early 80s, my boss used to say to me, the choice of hormone therapy is not depending upon the efficacy, but more about the toxicity profile and easiness of use. And you can see here the response rate in first-line metastatic, even with tamoxifen here, were really very, very similar. One big modification in concept appeared in the 1990s, in which for the first time we saw coming the aromatase inhibitor of 3rd generation, in which we realized that these compounds in fact were superior to tamoxifen in particular and to megestrol acetate as well. And conceptually speaking, was extremely important because it introduced the concept that some hormone therapy may be superior to other hormone therapy. This is the reason why the AIs actually became in postmenopausal setting standard of treatment, and today, as you know, we use them a lot. Knowing that tamoxifen is still a good drug, but there is a differential with hazard ratio around 0.80. The question some years ago was, are we heading to further improvement in hormone therapy? 15 years ago, I was doubting it after aromatase inhibitors. And very interestingly, we saw coming this drug, and I was involved in the development of Faslodex or fulvestrant. The mechanism of action was reviewed in detail by a previous speaker. The originality of this compound is really not acting against estrogen in competition like tamoxifen, or reducing the level of estrogens in the blood, but is acting in down-regulating the hormonal the estrogen receptors. And we realized in the lab that, in fact, there was a big potential, in fact, in interacting with the crosstalks, with, in particular, the PI3 kinase mTOR pathway. The development of this drug is very peculiar, actually. The first phase 3 trials were in fact looking at comparing fulvestrant at a dose of 250 milligram once monthly to anastrozole, which was becoming a standard after failure of tamoxifen. And I think in this trial, the results are shown here. We were quite impressed by the results because at that time, it's some years ago, having a drug which was really non-inferior to anastrozole, new standard, after failure of an anti-estrogen, was something we felt was very interesting. At the same time, as said before, there was clearly a dose effect seen here in clinical practice. 125 was significantly lower in terms of efficacy from 250 milligram. This was another concept. In our mind, the dose dependency of hormone therapy was not true. With tamoxifen, we never had any evidence. With the aromatase inhibitors, neither. So we were kind of surprised somewhere to see that maybe there was a dose effect. The second trial, in fact, went up against tamoxifen, using again the same dose at 250 milligram per meter square here. And comparing tamoxifen, first-line metastatic, to fulvestrant, 250 milligram intramuscularly. The results, in fact, in terms of time to progression, the main endpoint showed a hazard ratio at 0.18. In fact, there was no big difference, in fact, between fulvestrant and tamoxifen. And somewhere that created a problem to position this drug. In fact, where do we position this drug? And at that time, non-steroidal AI were a first-line standard. The question was, what do we do after that? Are we giving exemestane, the steroidal AI, or are we giving fulvestrant, or there was even the possibility to give tamoxifen? This is the reason why the EFFECT trial was performed, in which exemestane was a standard after failure of steroidal AI, was compared to fulvestrant, but we understood there was a problem of dose, so we were not sure that the dose was right. So in this trial, we got a loading dose starting with 500 milligram at day 1, and then 250 at day 14, and then 250 at day 28, and then 215 every 4 weeks. This was clearly related to the fact that in terms of pharmacokinetics, we had the feeling that starting with 250 upfront was not allowing us to reach in the blood a level high enough to have an efficacy, a therapeutic efficacy. This trial showed there was actually no inferiority between fulvestrant at 250 and exemestane after failure of steroidal AI. Nevertheless, there was still a problem. As a clinical developer, I was really considering that the 250 milligram was not the right dose, since we had some evidence that there was a dose effect with fulvestrant. There were two ways, in fact, to improve the efficacy of fulvestrant. The first one was to combine with aromatase inhibitor. The previous speaker talked about that. And I'm going to focus, in fact, on the increase of dose, which should further lower the estrogen receptor. These are the three doses which were used in development: the low dose, 250, 250, 250, then the loading dose, and then the high dose was delivering, in fact, upfront 500 milligram, at day 14 500 milligram, and at day 28 500 milligram, and then every 28 days 500 milligram. And you can see that the cumulative dose here is significantly higher when you use the 500 milligram. Very interestingly, this slide was already shown before, but there was a linear curve, in fact, with the dose from 50 to 125 to 250. There was clearly a decrease of estrogen receptor levels. And we were wondering, as clinical developer, why didn't we go up front to 500? Because clearly there was a question mark here. And I participated in this trial in the past, in which we were giving Faslodex subcutaneously and were able to reach very high level in the blood. And when you look at the 500 milligram, there is a potential, in fact, to decrease, to destroy estrogen receptor up to 98%. While with the 250, we were at around 60% destruction of estrogen receptor. So clearly, there was a question for the 500 milligram. Pharmacokinetically as well, I mean, we were convinced, and this is the real data, that with the 500, you reach very quickly a plateau, which is therapeutically efficacious. This is the reason why this trial CONFIRM was launched. In fact, a large phase 3 trial, 720 patients, in which really there was a comparison of fulvestrant 500 milligram versus 250. Time to progression was, in fact, the main endpoint. Indeed, the postmenopausal patient, because as you know, Faslodex was developed only in postmenopausal patient and not in premenopausal patient. And the patients were, in fact, patients who experienced relapse during or within the first year of completion of endocrine adjuvant treatment, either tamoxifen or aromatase inhibitors. When you look at the demographic of the study, a large study in which the age was comparable all along, in terms of less than 65 years old, as the majority of these patients here. In terms of weight, there was no difference between the two. When you look at, more interestingly, at the type of metastases which were seen in this trial, you need to realize that more than 50% of patients actually were having visceral metastases, so bone and visceral metastases, but more than 50%. This is extremely important, in fact, in understanding and interpreting the data. Previous cancer therapy, as you can see, there was a lot of hormone therapy used before. That was part of the tamoxifen was used, but AI were also used quite frequently. This slide, I think, is extremely important. This is the main endpoint, time to progression. The first thing you should look at is hazard ratio. Hazard ratio 0.80. 0.80 means it's a 20% relative improvement in the odds to be free of disease in favor of the 500 versus the 250 milligram. The second thing you look at is the confidence interval. Clearly, the upper limit is below 1, so you know the p-value is going to be significant, 0.006. You should be careful with the median. I mean, I hear all the time people talking about median survival. Median is just a point at 50%, and this slide is interesting methodologically because it's showing to you that at 50% here, we have what we call a cluster phenomenon. For whatever reason, there were a little bit more events in one arm compared to the other one at that very time. And clearly, when you look at the median time to progression, well, it's 6.5 versus 5.5, only 1 month. In fact, this is not the important point. The important point is the hazard ratio and the area under the curve, which is showing clearly that there is an effect. So beware of the interpretation of median in all the survival curves. The clinical benefit here, as you know, in hormone therapy, we consider that complete response, partial response, and stabilization more than 24 months are really what we should look at. And the 500 milligram showed a 45.6% clinical benefit as opposed to 39.6% in the 250 milligram. The duration of clinical benefit also was longer with the 500 milligram as opposed to the 250. The overall survival, this is initial data with 50% of the events, showed that there was a hazard ratio at 0.84. The number of events at 50% was not enough, so the p-value was not significant. But we got recently the final analysis with a 75% maturity here that was presented by Dr. DiLeo, showing that the hazard ratio was 0.81, so we are in the range of 20% improvement in terms of survival with a p-value this time which is significant, 0.016. One question which was really we were having is if we give Faslodex early and destroying the estrogen receptors, potentially down-regulating, are we going to have some efficacy of subsequent hormone therapy? That was a question we were extremely interested to look at, and in this trial it was looked at very carefully, and as you can see here, in both arms actually, the first subsequent hormone therapy, the response rate were around 35%, which is really what we would expect in this context. In terms of safety, increasing the dose, is it going to modify anything? As you can see here, there was no difference between the two arms. The only difference was potentially related to the pain at the injection site, although you need to be very careful with this drug. It should be injected very, very slowly. I mean, this is something, if you inject too quickly, you get pain at the site of injection. If you go very slow, you don't get a lot of pain. The rest of the side effects are very minimal, as we see in the majority of hormone therapies. The next study, I think, we believe after the confirm that really this drug now has the full potential in terms of efficacy, while the 250, we didn't believe there was a full potential. The first study is the next step, in which really John Robertson from Nottingham looked at really comparing anastrozole, which is a standard treatment, one of the best hormone therapy at the present, to fulvestrant 500 milligrams per meter square. These data are very interesting because when you look at the time to progression here, the hazard ratio is coming out at 0.66. So there is really a 34% relative improvement in the odds to be free of disease, free of progression, in favor of fulvestrant high dose versus anastrozole with a p-value which is significant. This is a signal that maybe we have for the second time a drug which is superior, in fact, to the other ones. So it's a step, progressively a step forward. There is a phase 3. This is a kind of randomized phase 2, 205 patients. There is a phase 3 at the present time running to assess, to confirm, I think, these important data. So what is, in fact, the typical sequence in practice? I mean, what are we doing in metastatic disease in sequence? Well, when we look really at patients who are endocrine naive, clearly, I mean, the aromatase inhibitors are actually clearly a good, best option, I think a good option. Tamoxifen remains in premenopausal with, indeed, ovarian ablation, either chemically or non-chemically a good option. And fulvestrant, I think, could be considered in context. In patients who are previously treated with tamoxifen or AI, clearly, there is a possibility to use tamoxifen, but I think fulvestrant here at 500 milligrams has a very good position. After that, I think clearly we know what's happening here in terms of further hormone therapy. The AI plus mTOR is something very interesting. The previous speaker talked about it. I think there is a big development which is going to happen here. A lot of trials at the present time I'm participating in the development of PI3 kinase inhibitors, for instance, CDK4/6 inhibitors, in which we use Faslodex actually as the drug of reference. Faslodex, through the mechanism of action, is in my mind in between the classical hormone therapy and the biologic treatment, acting with the crosstalks with the PI3 kinase and mTOR pathway. What is the conclusion of all that? I think what I want you to bring home is hormone therapy should always be considered in first-line metastatic for patients with luminal tumor and no life-threatening disease. It should be used in sequence. This is the second thing, and potentially trying to exhaust progressively the hormone sensitivity using the new inhibitors of the mTOR pathway, PI3 kinase pathway, to try to reverse some of the resistance. The 500 milligram of fulvestrant is clearly superior to the 250. We have some clues that there may be some superiority to anastrozole, to a non-steroidal AI. There is clearly a potential for further development. We should go up. There are some trials which are being run right now in early breast cancer. The combination with biologic modifier is very interesting. And I think overall this drug, in my mind, has added a step further in terms of hormonal management of breast cancer, and has added a new option in patients in particular who are sensitive to hormone therapy, who are gaining time before we'll get to chemotherapy with more side effects. Thank you very much.
Thank you, Professor Jean-Marc, and I think it is now the time to discuss the two presentations together.
Can I start the discussion? Can you put the light on, please? Professor Nobel, thank you very much. We are happy every time to have you. We are happy to have you again and again in Cairo, and we usually learn from you the very updated knowledge about hormonal treatment in hormonal dependent breast cancer. I would like to discuss with you and with the audience as a clinician what is the real situation of Vaslodex in the line of hormonal treatment. So I suggest a case of a postmenopausal woman with a very good general condition, and she is on hormonal adjuvant treatment, which is aromatase inhibitor, non-steroidal, steroidal, and then she developed 2 sites of bone and visceral metastases. And according to the NCCN guidelines, I have many options. I either to shift it to steroidal, I either add mTOR, or I go upfront to Vaslodex. So, do you kindly enough give me some pointer to the time of relapse, or the symptoms, or the KI again 67, or tumor marker may suggest one way or another?
Well, I think it's a very important question that you're asking. In fact, the management of breast cancer, I mean, the NCCN is giving a lot of recommendation. I mean, they are giving choice. I mean, the problem is as clinician, we have to decide for specific patients. So this is very important. The main line you should keep in mind, from my point of view, is in the sequence of hormone therapy, there is no predictive factor specific which is going to give you to use either one or the other one. This drug is working in visceral metastases as well as in bone metastases. So as soon as there is an indication of hormone therapy, no life-threatening and positive hormonal receptors, I have the tendency to start with hormone therapy and try to delay the access to chemotherapy as long as possible. The choice of the sequence after that, I have a tendency to use first the most powerful hormone therapy in my mind. So there is a graduation in my mind. Tamoxifen is one of them. One step further with a 20% relative improvement is the aromatase inhibitors. One step further in my mind is Vaslodex 500 milligram. The mTOR addition is something which is very interesting because this is really something extremely important. And the position today, I have a tendency to use the mTOR inhibitor after failure of at least one line of AI. So it's giving me a choice, but I use Vaslodex relatively early. I mean, when I have patients previously exposed to AI and they relapse after adjuvant treatment, I have a tendency to use Vaslodex 500 very early. And then I go to exemestane plus everolimus. That's a personal use based on my interpretation of the data, showing that there is a graduation in effectiveness of this compound. I believe today Vaslodex 500 is the best hormone therapy we have. And things are going to move because a lot of the trials being done at the present time with the PI3 kinase inhibitors and the CDK4/6 inhibitors are actually using Vaslodex as the base, because we believe that this is probably the best drug for interacting in the crosstalks between ER and the pathways, PI3 kinase and mTOR pathways.
Professor Jean, you believe that the sequence of the hormonal treatment is the important, or use all the hormonal agent in a hormone-sensitive tumor?
Well, I think I believe that the sequence is extremely important. We need to exhaust the hormone sensitivity. Then the choice of the use in sequence after that, we don't have very strong data to. I have a tendency, as we always did in the past, to use first potentially the best one, then go down the line. And we know that as we go down the line, the probability of response is going to go down and the duration of control is going to decrease. So that's the reason why I'm using first the most powerful one to get the best response and as long as possible. And then, but that's a personal interpretation. There is no phase 3 trials which are actually confirming that. But yeah.
Okay, when you use the Vaslodex with the approved dose,